Hi, everybody. Good evening. I see Dr. Leong, Dr. Kaur, sorry. Dr. Kaur is a Dobbs member and a faithful, active participant. Welcome and good evening. Let's hope more and more people come in. So with me tonight is my good friend, Dato, Dr. Amar Singh. Hi, Amar.
Hi, Alan. Good. I'm fine. Good.
I heard Ipoh is getting all sorts of visitors with outstation cars, and the numbers have shot up recently.
Yeah, I think some people have been running away from the MCO area to our more relaxed area. Yes.
Anyway, tonight's topic of discussion and stems from a recent letter which actually Amar penned, and we'd like to actually address, because I think it's important that the public as well as the healthcare workers be aware. I mean, I think what we're going to talk about is deaths which might happen after COVID vaccination, and how people may misconstrue this if should it ever happen. God forbid it won't, but should it ever happen. Hello, good evening. So Sunita, hi. We are only streaming to YouTube, and it's a public stream, so we welcome comments. We will address the comments by answering on this stream, but we can also text if you can't hear us very well. But if there's any problem with the feed, let us know. Okay, let's see. Okay, we got a few more viewers. We can start anytime, Amar. I think maybe I will share something. You know, the news has always been sometimes sensationalistic, right? You know.
Yes.
And then when we recently, this was published in the press. Actually, they say it's from one of the vernacular newspapers. And then when people read this sort of headline, Indonesian nurse dies 9 days after receiving China's Sinovac vaccine. I mean, if you don't read the details, you may not know, you know, you might get the wrong inference, come to the wrong conclusion, and might be afraid of vaccination. And actually, if you bother to read the details, the unfortunate individual is a 33-year-old nurse who died 9 days after receiving the vaccine. But actually, the cause of death was that she had contracted COVID-19. So that she died of COVID. And then, if, as you know, with only one dose, it would be inadequate protection. Yeah. So she's so unfortunate to have died before she was adequately protected against severe COVID by vaccination. So that's the sort of thing, and a lot of things being shared on the social media, WhatsApp, and so on, which does sometimes concern us, healthcare professionals, and I think this misinformation needs to be addressed. Okay, if you're here to preempt misinformation, there's another greeting there. Hi, Dr. Wong, welcome. Yeah. Okay. All right. So, Amar, you want to kick it off?
Yes. Thank you, Alan, and thank you for that good introduction, and that sets the stage. Let me just pick up some slides and share them with all of us. All right. Alan, can see the slides?
Yes, the
Okay,
slides
good.
are up.
Yeah.
Yeah.
So I'm going to talk about two issues. The first one is this whole issue of deaths. The second one is severe allergies. And I'm not sure what word to use. Whatever word we use is going to be, difficult to accept or maybe misunderstood. We've used expected. Some people have used spontaneous, others use baseline, others use natural. Some may even use the word fated. But these are deaths that are happening post-COVID vaccination, but would also happen without the vaccination. Okay. And the second thing, as I said, I'd like to talk a bit about what to do if you have severe allergy. And of course, the person we're thinking about is the older person who's going to get vaccinated. So I'm going to talk about deaths in older persons, some idea about side effects and adverse monitoring and allergies. Okay. So we, as Ellen said, we put out this article because we wanted people to be aware. We don't want that kind of sensational news to spread. And this is the kind of news that has already occurred when Norway first put out its data, and they're very good. They put out all the data in the public eye, and people had this kind of headlines: 23 elderly people die after Pfizer shot in Norway. And again, you got to read the contents or you get misled. And here's another one: fatalities that shocked the world, okay, or concern over the vaccine. But good media reportings would then go and say, many were old people in nursing homes and so on. So how the media portrays information is very important. And we as individuals also may share information, and how we share is important. So what is this baseline mortality, expected or spontaneous death? This is older people who are going to die from some disease, whether they have the vaccine or not. And this is data from US suggesting what that proportion is. And for people aged 65 or above, about 4,000 per 100,000 will die every year. And of course, the older you are, the more likely you're going to die. So the figure I think that's easiest to remember is this: if you're past 65 or 65 or older, then and you've got 100 friends, you're going to lose 4 friends every year in that category. And that's the kind of figure to remember. And of course, if you're much older, past 85, then you're going to lose about 10% of your friends every year. And so this is a reality, and we seldom want to talk about death because it's a taboo subject. But as we grow older, we have to face our mortality. And what do these people die of? The same, when you look at US data or Euro data or Malaysian data, they die of myocardial infarct, a heart attack, they die of a stroke, some of them die of cancer, and some of them die from infection in the lungs, usually a viral infection or some lung damage. That's the commonest cause in people of age 65 and above. Okay. So if we translate this data into Malaysia, we look at what is this expected spontaneous or baseline mortality, and we use the US data to reflect on ours. We know that we have about 7 million of our population, 7% of our population, which is about 2+ million people aged more than 65. So that's the number of expected deaths per week without a vaccine. Again, I like to translate this down to 100,000 for us to easily remember, and it's 75 per week per 100,000 older people. And that's the kind of deaths we are going to be seeing without vaccination in our country. So I try to make it graphic so we can understand. Without vaccination, every week, 75 people for every 100,000 Malaysians aged more than 65, okay, 75 people are going to die. Now, this number will vary, of course, and we've recognized that during the lockdown, some deaths have reduced, and that's people dying on the road. And of course, some viral illnesses have reduced because everyone's trying to wear a mask, so maybe some influenza deaths may go down. But this is basically what's going to happen every week. Okay, so this is what's going to happen after vaccination. We're still going to get these same deaths happening. Okay, and they're going to happen just as they occurred before the vaccination. If I graphically give this to you, another way to look at, here's a gentleman who's 82 years old with significant hypertension, bad hypertension. He has a stroke, and 5 days later, he dies. Okay, now imagine this same individual had a COVID vaccination 2 days before his stroke, and then he died, of course, 5 days later. So everyone's going to then assume, and you might get a social media post, or you might get a media outlet, man receives COVID vaccination and then develops stroke and dies within 1 week. but actually he was going to get a stroke. It's a baseline event. It's an expected event. Again, the choice of words is very difficult. So this COVID vaccination creates an a temporal relationship, artificial temporal relationship with this event that was going to happen. And as I said, this may be amplified by people on social media. Okay. I like these words from this professor from France. He was writing in response to what happened in Norway. He says, in older people, due to their greater frailty, a significant amount of spontaneous mortality is expected. And that's the word he used, spontaneous mortality. It's therefore difficult to directly attribute these deaths to the fact that these people were vaccinated. I believe that the way forward is data transparency about adverse events. All countries, including Malaysia, should publish for the public to look at all adverse events that occur ongoing. And this rapid open data sharing is what will kill rumors and also not allow anybody with an anti-vaccine kind of outlook to capitalize on them. Okay. Now, this is not anything new. We've seen in much of our life, people have tried to implicate vaccines for deaths. And here I purposely, as a pediatrician, chose a pediatric example. Here's a review of 2 million children who were vaccinated, and there were 76 deaths within 30 days of vaccination. And what did the children die of? When they reviewed them, they died of suicides or homicides or accidents or cancer. So there's no association with the vaccine. But in somebody's mind, they might associate this. Okay, but these are natural, spontaneous, expected deaths that are going to happen in individuals. Smaller in children, larger in old people. I want to come back to this slide and say that, although we say 75, the number of deaths each week is going to vary. It's not a fixed number. And, it's going to fluctuate. And the number that we may monitor before the vaccination and the number that we monitor after vaccination may vary each week. So we should only be worried if the rate per 100,000 of these kind of natural or spontaneous deaths goes up significantly. The way to do this is to monitor weekly and to, of course, make that data available and, of course, monitor ongoingly and cumulatively add the data together. Okay. So when I talk about data transparency, I love this Norwegian group. They believe that it's important to be transparent about adverse events and publish them. They publish them weekly. And I believe that transparency about adverse event is what builds trust with our public. Okay. I recommend their website to you. So here's data from them that they publish every week. This is up to the 16th of February. And this is a total number of reports of adverse event by the type of vaccine that they are using. That's a number of deaths that have occurred, serious events, and other non-serious events. So right now they've had 93 up to 16th February deaths on people who are vaccinated. They're taking 2 weeks following vaccination. They're being very generous. Some people might take 1 week. This is 2 weeks. And the majority of them were old or frail or people with multiple illnesses in nursing homes. And there's currently no link that they can find between the vaccination and these deaths. And they say this word death is being reported for completeness. And I like that they're being very thorough about the safety profile of the vaccines. So what does Ministry of Health plan to do? What is our Ministry of Health plan to do about side effects and adverse events? They're planning to survey. They've always done this for every vaccine that we launch ongoingly, as well as for new vaccines. And people are going to start receiving notifications through the My Suggestro app to report any adverse events following immunization, AEFIs. Okay? There are 3 ways the public can report the side effects, and we encourage the public to report side effects so that we can monitor them. You can inform the medical facility where you had the vaccine. You can use the My Suggestro app, or you can go to our National Pharmaceutical organization, run by the Ministry of Health, and use the CONSERV, which is Consumer Reporting of Side Effects, on their website and report it there. Ministry of Health also says that they're going to set up a committee to assess the AFI cases as they occur. And I hope that they will make this, committee reports available to the public, both the total reports as well as the committee opinion. Okay. Now, I've discussed that deaths, but I want to say, the thing that we are very worried about is deaths if you're infected with COVID. These are people without COVID infection. And we also worry about this thing, which is still not very clear, how many people who don't die but develop long COVID. Nobody's really sure of the percentage. It's between 10 and 30% people who develop brain fog or chronic fatigue and can't do things that they couldn't go back to work, couldn't go back to school. And that's a big worry to us. But also deaths infected with COVID. And let me discuss the deaths in older people. Now, we know from US good data that the vast majority of cases occur in younger people. That's the cases here in red. They occur in younger people under 50. But the vast majority of deaths occur in people over 50, more than 95%. And that's this one in blue. Okay, so it definitely means that less chance of getting infected, but higher chance of dying. And they've put up this graph, the CDC, comparing the chance of dying compared to young children and teenagers for every age group, every sort of 10-year bracket that they have there. And it's phenomenal, the difference in rate. This has been replicated in many other countries by studies looking at age-specific mortality in different countries. And it's true for any country, whether it's Malaysia or Korea or India or China. We all have this gradient as we grow older. And of course, men have a higher rate than women. This one is a bit harder to understand. I like this other data from CDC, which they put up, where they compared within the age group. So if you're past 85 and you have COVID infection, 1 in 5 is not going to make it. Okay, and that's if you're 75 to 85, about 10% of them I'm not going to make it, slightly more than 10%. And if you're 65 to 74, 1 in 23 are not going to make it. So this kind of figures to remember, especially these old people, 1 in 5. So I think this is what spurs us to get the vaccination. These are the people that we want to protect. And this is why many countries are vaccinating older people to protect them. Having said that, some countries have looked at the Norwegian data of older people, vaccinated and dying, and they've decided not to vaccinate older people. In UK, of course, it's vaccinated. In Malaysia, we're doing so. But in France, Germany, Sweden, Austria, Poland, Italy, they've gone to vaccinate people who are younger. I hope they change their advisory because, there is concern that if you don't vaccinate the older people, you leave them vulnerable to COVID and a very high mortality risk. Okay. So I've done that fairly quickly, but I'm open to questions. I'd like to handle the second one, which is equally important. What to do if you have a severe allergy? And this is something that a lot of people have asked me in the last couple of days as the vaccine has become available, not just lay people, but also my colleagues, some of them consultants who have a problem with allergies. And I myself have a problem with allergies, which I will share with you. Okay. So under our national COVID-19 immunization program, they've got the statement under precautionary measures, individuals with severe allergies, further consideration is required. And then recently, the National Pharmaceutical Ministry of Health Association has come out with this infographic. It's also available on their website, saying that the Pfizer vaccine must not be given, very clear now, must not be given to someone who's allergic to any of its ingredients and someone who had a severe allergic reaction to the first dose. Okay? And they also ask, if you suffer from allergies, ask your doctor for advice. So this is a little bit blurred. I'm not sure what the doctors on the ground are going to do as well, unless they do extensive reading. And I'd like to share with you some idea what to do about these allergies. Okay. So we know that currently more than 200 million doses of the vaccine have been administered worldwide. Close to 50 million people have received the complete vaccination program. That means 2 doses. And I'm going to look at 3 data sets. I'm looking at the CDC US data sets where they publish adverse event reporting. I'm going to look at UK health yellow card reporting, where they make available to the public all adverse events after being vetted by their committee. And for the Norwegian one, the one I mentioned, the adverse registry, which they keep and publish weekly. Now, here's a summary of those 3 databases for all the vaccine. It's maybe a little bit busy numbers, but the first column here is the number of vaccinated doses that have gone to individuals, number of vaccine doses by different vaccines when available. Here's the total number of adverse events reported, small and big ones, all reported to individuals. Here's a number that I'm concerned about. I'm trying to talk to you now about severe allergy problems, and these are people who develop a severe allergic problem to the vaccine. And what do we mean by anaphylaxis, anaphylactic reaction? These are people who had a very severe, nasty allergic reaction. Their blood pressure may have dropped. They had breathing difficulties. They developed a skin swelling and a rash. So these are people who develop a life-threatening allergic reaction. You see, there's a reasonable number there. But here's the most important one, this column in red, which is the number of people who had an anaphylactic reaction, a rate per million of anaphylactic reaction. And you can see for the CDC is 4.5. They mixed up the two vaccines, very hard to tease them out. For the UK, the Pfizer vaccine was close to 19 per million. For the AstraZeneca, 12. For the Norwegian, for the Pfizer, was 9.6. And for the Moderna, none. But the numbers may still be small here for the Norwegian one to say anything here, okay? Because we're talking per million here. Now, why are there different rates? One, because this is a rare event. These numbers are very small, okay? Secondly, we're dealing with different countries where the genetics may be a bit different. And thirdly, we're dealing with different vaccines. Of course, they've also been publishing the number of deaths, which we talked about earlier, the spontaneous or baseline deaths that occur. Okay, so I've combined the three data sets for you. There are about 27 million doses, about 200 plus anaphylaxis events. And this is the current rate from that huge data set, which is about 10 per million doses. Again, I think the simpler number to remember is 1 per 100,000. So currently, if anybody asks me, for 100,000 people in Malaysia who get the vaccine, the COVID-19 vaccine, one of them is going to get a severe reaction, which means they're going to need immediate medical assistance. They're going to need some adrenaline, possibly. You know, they may need to be hospitalized for a short while. So far, none of these 276 people have died, but they've all received urgent medical attention. Okay, most of them have been discharged. Now, this number is still very difficult to decide if it's a final number, because this number, the number of reported anaphylaxis, is a very small compared number of doses. Now, I'm quite interested in statistics, so I do, statistics is part of my job, and I calculated a confidence interval for rare events, and it's 0 to 20 per million doses, which means as we give more and more doses, this number may come down to close to 0, or it may go up to 2. So I can tell you right now that this number is a preliminary number. It may be as high as 2 per 100,000, or it may be low as almost close to 0 per 100,000 as more people get vaccinated. We've noticed even in UK, initially they had a number of anaphylaxis events. After that, the number gradually dropped. Okay? The data I think we need, which we are not receiving from anybody at the present moment in the world, is how many people who had previous anaphylaxis, that means in their life they had previous nasty reaction to a drug or a vaccine or food or some item where they almost collapsed and died. I've had children who I've treated who had anaphylaxis after egg or after eating some protein or even after a vaccine. You know, this is an unexpected allergic reaction. It happens. As doctors, we recognize we don't know who is going to happen to, but can happen. And we want to know these people who had this kind of reaction, how many of them develop anaphylaxis after this COVID-19 vaccine? And similarly, you want to know how many who got major allergies develop anaphylaxis. We don't have this data. But what data we have from CDC is a report where they discussed 21 people who developed anaphylaxis. And of the 21 who developed anaphylaxis, 80+% had documented history of significant allergy reactions in their lives. That means allergy to drugs or medical products or food or insect stings. And 33% had a previous episode of anaphylaxis. Now, this is not the same as the kind of data I was asking for. This is a tiny reflection. This is looking at the other way. I'm looking at this way. So you must remember that a very large number of people with allergies has received the vaccine already. Hundreds of thousands of people who suffer from drug, medical product, food, insect sting allergies have already received the vaccine and had no reaction. So we need that kind of data, which we know has already happened. Okay, but maybe that kind of data is harder to get. Maybe if we use our MySuggestra and we all report our allergies there, maybe MOH could give us that kind of data. Okay. So what constitutes a severe allergy? You may be asking yourself. You know that this is my own take on this. You know, I'm not an immunologist, but I read quite a bit, and these two articles have been extremely good. One from Italians, another from UK, and you know, one of them has suggested that we should grade allergies, and I agree with them. And so I put this 6 grades, and I'll talk about the grades in a moment. And here at the top are people who have developed an anaphylaxis before, and as I talked about it, these are people who develop some body swelling, some rash, some obstruction to their breathing, BP, the blood pressure drop, and some of them may be in comatose. You can possibly die from this unless you receive urgent treatment. Then there are people who develop a lot of edema, swelling of their face and neck, but it's called angioedema, but they don't have changes in the blood pressure or airway problems. If they had, I'll put them up here. Okay. Thirdly, there are people who develop hypersensitive reaction to vaccines. This could be to any other vaccine, and the important product in vaccines that's causing this is something called polyethylene glycol and polysorbate 8. Polysorbate 8 because it behaves the same way as this one. There's a cross reaction, but polyethylene glycol is the main one. And this is not just available in vaccines, it's also available in some drugs. And fourthly, the one that's very common in individuals, many people have some degree of drug allergy, and whether that's extensive drug allergies like in my situation, or whether it's mild drug allergy, varies. I put severe asthma here because there's some literature suggesting that uncontrolled severe asthma has a relationship with anaphylaxis, and we need to think about it, but it's not that high up. And finally, many individuals have this. It's estimated that 10-20% of the entire population of any country will have urticaria, where they have some a little bit of skin swelling after maybe eating something or drug, eczema, allergic rhinitis with their nose maybe temperature or dust sensitive, contact dermatitis where they touch something and develop a rash, food allergy, and insect allergies. Okay? I must say again, insect allergies, there's one that I'm particularly concerned about in reading. That means if you're a bee sting and you develop a very nasty reaction with bee sting, almost anaphylactic-like, then you need to be a bit careful. Okay? But generally, most of these people have no anaphylaxis and no angioedema, so I put them down here. So if I divide them, this is how I divide them: severe allergic reactions, moderate allergic reactions, and mild allergic reactions, which is a significant proportion of the population. Some people quote 30% of the population have these. Okay, so how do we deal with each of these? Do we give them vaccines? I mean, we cannot not vaccinate another 20-30% of the population. Already we're not vaccinating our children, and there are some people who are too ill to be vaccinated or have diseases that don't allow them to be vaccinated. So we need to vaccinate as many of our population as we can. So what have other countries said? UK was initially conservative, but now they've said this statement. They've said that anyone with a previous history of allergic reaction to the ingredients of the vaccine should not receive it. But those with any other allergies, such as food allergy, can now receive the vaccine. Okay. The US says that, again, severe allergic reaction means anaphylaxis to a previous dose of a COVID vaccine. You got your first dose, you develop a very bad reaction, or any of its components you should not get, or you've had immediate allergic reaction to any of its components. This does not mean anaphylaxis, but immediate allergic reaction. And thirdly, if you had an allergy to this polysorbate, then or this polyethylene glycol, then you should avoid. Okay, I don't feel these are specific enough for us to use, but they're there. The American Academy of Allergy and the American College of Allergy, Asthma, and Immunology have both come up with statements. One saying that if you have a history of food, pet, venom, environmental latex allergy, you're able to continue the vaccine, but please observe them. And even if you have anaphylaxis, they say you can go ahead and be vaccinated. This is not anaphylaxis to the vaccine, but anaphylaxis in past history. I think this is something that many people have not accepted, but notice how such an authoritative body have come out saying this. Okay, and similarly, this college has said that that all these allergens that you have don't make you more likely to have allergic reaction to the vaccine than the general public. WHO has come up with a simple statement saying that if you have a severe allergic reaction to any component of the vaccine, you should not take it. Closer to home, I like the advisory from Singapore, which they came out in January. It's a very detailed advisory. I'm just showing you a small part of it. They've discussed all the issues of who can and cannot take the vaccine, and I recommend their website to you. And basically, they said, if you've got a history of anaphylaxis or severe allergies, don't take the vaccine at the present moment. If you have allergic reaction to the first dose of the vaccine, as others have mentioned, don't take it. This is the one that they're different to everyone else. They say a history of severe drug reactions, don't take the vaccine. But if you got atopy, allergic rhinitis, well-controlled asthma, you got eczema, go ahead and have the vaccine. So the difference is this one, where you have severe drug reactions, and where they mean by that is multiple allergies but no anaphylaxis. And this is a problem. I'm in this category as well. Okay. So I say that currently this is the MOH advisory. I hope that they will give us more details, especially give the medical doctors more advice because a lot of people are going to be approaching them. But I want to talk about myself and what to do. I'm somewhat in number 2 and number 4. I've had a previous angioedema, nasty one. I've also had one episode where I had airway obstruction, partial airway obstruction due to an allergy, and I have very many drug allergies, some nasty drug allergies. So obviously, I'm number 2 and number 4, and probably should be considered severe. What is Amar going to do? Huh? And here's my game plan, my 3 options. As people who know me, I often think of at least 3 solutions to any problem. And the first thing is avoid the vaccine completely if you're in this category. Now, don't avoid the vaccine if you're in this category, which is a large proportion of people. I'm talking mainly about people in this category. So avoid the vaccine if you've got severe allergic reactions or anaphylaxis. But as you well know, the vaccine is going to become some sort of passport for movement. Not just the big things like vacation out of the country, which we can do without, but movement around, freedom to take more. You still have to wear your mask, you still have to keep your SOPs, but there's a lot more less restrictions placed on you. Maybe you got to attend a conference and stuff like that. So I'm not very interested to have my life restricted. The second option is, okay, go for broke, vaccinate in a hospital, have a good physician friend. And of course, I can do that. I've got good physician friends, but can the average person do this? Can they ask? But I hope that this becomes the advisory. In the Singapore advisory, if I could come back to that, where clinical risk benefit strongly favors vaccination. Vaccination should be conducted in a healthcare facility with immediate access to treatment. And they were talking about people in this category who, for some reason, need vaccination. Maybe they are healthcare professionals with high risk. So vaccinate them in a health facility with immediate access to treatment. All right. So this is not in a clinic. This is not in a stadium center. This is in a hospital center with specialists. Not even in your casualty, probably in the ward setting with adrenaline at hand, as I put there. So I hope that this becomes part of our national advisory for people who are in this category with severe allergies. But this is the option that I'm going to probably take for myself. I would like to delay the vaccination for a short while. I want to keep watching the data as it comes out, and I hope more and more data from many countries come out to publish not just general data, but data on which vaccine and what is the anaphylaxis rate for that vaccine. Okay? Then I hope that we are able to choose the least allergic vaccine for this category of people, preferentially choose it, and of course, still vaccinate them in hospitals with a good physician background. So that's my game plan, and I'm happy to hear what other people can suggest. But I think avoiding the vaccine, if all of us with severe allergies avoid the vaccine, I think may be tricky long term for us. Okay. Finally, of course, if many people get vaccinated, those of us who have difficulty getting vaccinated are protected, and that's critical. When many of us get vaccinated, we protect the children who can't get vaccinated. When many of us get vaccinated, we protect the person, who's got a severe illness, who's very ill and can't get vaccinated. When many of us vaccinate, we protect, people who have got severe allergies who are currently a little bit hesitant about getting vaccinated. So, Alan, that's what I'm going to stay for now, and back to you.
Thank you for the great comprehensive overview on covering 2 things: baseline expected mortality, and secondly, the vexing problem of allergies. I even have a family member who's concerned. She's a doctor, but she's got multiple allergies, and she's concerned about the vaccine, where to get the vaccine, and so I think we have to seek clarity on whether or not we can be reassured that the vaccination would be at the center. We are confident there would be the so-called support should there be an anaphylactic reaction.
Yeah, I think the support we need is not just the adrenaline, but physicians who are capable in managing anaphylaxis, and the anesthetic team who can intubate you if you haven't come to that stage. I also have a consultant who called me up, and she's had 2 anaphylaxis events in her life. So she's, very worried about taking the vaccine. I share her concern as well. Yeah.
Yeah. Okay. Evelyn, thank you for your comment. You said my Sajatra doesn't give option of stating you have an allergy. And no choice where the person will. Is that okay? First thing, when you register your intent for vaccination under My Sejahtera, they ask a few questions, isn't it? If I'm not mistaken, I think allergy is one of them, and then whether you have cancer or some other immunocompromised state. Anybody know?
Yes, Ellen, you're right. I went and looked, I haven't registered yet, mainly because I don't want to put myself in the queue and then suddenly I say, sorry, I'm, I can't get the vaccine yet because of my allergies. So, but I went and looked, and I think there is a statement for allergy. But the second part, Evelyn is right about the second part. You have no choice where to get vaccinated at present. Having said that, I've looked at the process of what we're doing here in Perak, and it's a very streamlined process. They even put out a video of their steps, what's going to happen to you. So you are going to get consulted when you come on that day. Someone is going to take a detailed history from you. At that point, a decision is going to make whether you are safe to vaccinate or not. So I think there's still that safety net for us. Yeah.
Evelyn says there's an others, click on others, there's no further drop down box.
Okay.
I'm not sure, but I vaguely remember there was. But
I
anyway,
still remember seeing,
yeah, but I can't go back because I've already answered the question. The concern actually, if the layperson, you ask them about, have you had allergies? Some people have no concept of allergies. They say, oh, I vomited after taking an antibiotic, so I'm allergic to that antibiotic. They may not be aware what is a true allergy. So I think the thing about really another layer of screening and proper history taking is important to know whether it's true allergy. But it's also comforting for the statistics so far that from you mentioned, the CDC, you say category states if you have prior allergy to something, it doesn't mean you will be allergic to the vaccine.
Correct.
Which makes sense, isn't it? It makes medical sense because you
Yes.
need to have previous exposure to a component and then get a hypersensitivity response on that exposure to the vaccine. So if just because you're allergic to peanuts, for example, it doesn't mean if you have the COVID vaccine, you will get a severe allergic reaction.
Fully agree. So I think all the people who have the, food and milder drug allergies and the hay fever and allergic rhinitis, all this should go ahead and have their vaccination. Just tell the doctors that you have those, and people are probably a little bit more cautious with you. That's all. And just take a bit more care. Maybe stay a bit longer before you go back, that kind of thing. But most of the allergic reactions are going to happen within 30 minutes. They're not going to happen further down the road.
Yeah. So careful observation post-vaccination for the rare severe allergic event. The emphasis is rare. Although we pay heed to it, it is rare. Yeah. So Evelyn has got one more difficult question. How can a person know they're allergic to the polysorbate?
Well, I think the only way, if you're a pharmacist and you know exactly the contents of the drug or the vaccine you've taken in the past, even this is new to me, Evelyn. I hadn't really known about PEG very much until now. But that is the item, and polysorbate 80. Those are the two items that actually are the ones that are linked to allergies. But, PEG is in many compounds, many drugs as well. So I think consult a pharmacist. That's the only way. One way is to go back and think of, if you had allergies, go back and think of the drugs that gave you the allergy, and then go back, look at the content of that drug. Because it's not just a drug inside, there are other components inside that formulation. And again, our pharmacy friends could help us with this.
Okay. I hope, people who have watched this or are watching this would be at least allay their fears of deaths or whatever they've been reading in their social media and all that. That if of 200 over million doses of the vaccines given worldwide, to date there has been no safety signal where there's been an increase in mortality rates. None. I think people should be aware, and I think we need to preempt, the deaths which are going to happen after vaccination because of this baseline deaths which happen every day. I think that would be the take-home message. Number two, the only safety signal we are concerned about to date is allergic reactions, but even then, anaphylaxis is pretty rare.
Yes.
Pretty rare, but still, I think something which we need to observe for, particularly people with an allergic tendency. And and whether or not we differ in people with severe allergy, severe anaphylaxis, I think it's something for the authorities to decide.
Yes.
I think,
Agree. Alan is a very good summary, and I think both Malaysia and Singapore are more conservative. Notice some of the other, advisories I mentioned, even with prior anaphylaxis, they say go ahead, just watch a bit longer. So I think it depends on people's experience and comfort, but also the kind of, as we mentioned earlier, the kind of health setting you're going to be in to deliver this. Yeah.
Dr. Kaur has statistics. In the US, 60 to 70% of antibodies to PEG.
Kaur, you got any reference for me? I'd like to read up on that, definitely, Yeah, but PEG is not uncommon product, as much I've learned, yes. But you may not have a PEG allergy, though. That's a different story entirely. Yeah? Okay. So you're talking about people who, after taking a vaccine or a drug with PEG inside, develop a severe allergic reaction, which means they had anaphylaxis, not just develop some mild rash. Okay.
So PEG is polyethylene glycol, yeah, the
Yes.
component in the Pfizer vaccine.
Yes.
We'll have to. I don't know whether that figure is correct, but we will like to see any reference. Okay. Yeah. So there's a question. Allergy to penicillin. Please elaborate on this issue. Thank you.
I think a number of different health authorities have come out. Just because you're allergic to penicillin doesn't mean you'll be allergic to the vaccine. Now, if you got a penicillin, you develop anaphylaxis, that's a very different story. That's what we're talking about. That means you got anything, whether it's a bee sting or a drug like penicillin or any other drug or a food, and then after that you collapsed. Your blood pressure dropped and you couldn't breathe and you had swelling everywhere, even in your lungs. That I think you should be cautious with. But many people have penicillin allergens. I myself am allergic to penicillin as well. That is not something that restricts us from getting the COVID vaccine. That's been very clearly stated.
Okay. So if you get, let's say, a mild rash, itchy rash after taking a penicillin antibiotic or something else, that is not in the same category as somebody whose blood pressure drops or gets very breathless and has throat swelling and cannot breathe. That's major anaphylaxis. So those we need to really not take the vaccine or defer until we have more data. I think that but the Singapore advisory is quite conservative.
Yes.
Yeah, regarding
it is. I think that they're also doing it because they're starting out the vaccine program and they don't want anything to damage the vaccination program. I think that's wise. And as they go down the road and become more comfortable, then I think they will do this. I think the MOH will do the same as well. Initially, we're a little bit more restrictive and then become more, as we learn more. I mean, all of us on a learning curve with COVID all the time. And the vaccines.
Okay. We've got a fairly decent amount of viewers, but any Dr. Kaur wants to ask whether we can address his earlier question on the Sinovac vaccine. Not really to do with what we're covering, but we should try to answer.
I get an enormous number of questions about the new vaccines, and I have refused 8 talks on vaccines, including one from Alan, because the whole vaccine thing is so huge. The amount you have to read and stay abreast is difficult. And our problem with Sinovac is data. That's our problem. They have published phase 2 trial data. They haven't published phase 3 trial data. So Sinovac vaccine is different. They use an adenovirus carrier, and so it's an inactivated virus that's being delivered to you. Not the mRNA as the other vaccines it is. So, this is like something like the old-fashioned vaccines that we are getting, in a sense, inactivated bug that they're giving to you. So the claim is safer, but we have not seen the data. We need to see published, not newspaper media articles, but published, peer-reviewed phase 3 trials where we see both the effectiveness of this vaccine and the side effects of this vaccine in a controlled trial where, one arm is given the vaccine, one arm is not given the vaccine. I think then we can understand this. Some of us believe the reason this is not published is because China has got so few COVID that they can't show effectiveness, even though they have vaccinated a lot of people. So we're looking towards Brazil, where much of the study has been done, and maybe Indonesian data later. So right now, hard to say it is safer or not safer. We have not seen. Whereas the Pfizer vaccine and the other vaccines that are already approved, we have had, as I showed you just now, more than 20 million doses which have been delivered and monitored and published results. Of course, in the worldwide, it's 200 million, but it takes time for that data to be published, and not everybody may publish their data. But from the US, UK, and Norwegian one, you can see that their safety profile in the real world, not just in the studies that they have published. Can't
As
answer
whether
this question. Yeah.
I think his question is whether it's old or new. I suppose it is a new vaccine, but it is based on old vaccine technology where you're using an inactivated virus. Okay, I think as far as what you asked about long-term side effects in the Pfizer vaccine are concerned because it's fairly new technology using mRNA to produce the spike proteins to elicit the immune response. Now, what are the long-term side effects? Nobody know because we haven't reached the long term yet. I mean, but as far as the safety signals to date, since the phase 3 trials were published, and we already have quite a number of months to go. I mean, there's no immediate safety concerns other than allergies, as far as my understanding goes. Yeah. Any other conspiracy theories or misconceptions that mRNA, is going to alter your DNA and all that, which is going around. Maybe they have a little bit of knowledge about reverse transcriptase, and they think that any mRNA and reverse transcriptase means it will alter the DNA. No, it's not going to happen. Okay, the mRNA will not, unlike coronavirus is not a retrovirus like HIV. HIV will embed itself into the DNA, okay, and they have specific reverse transcriptase primers, and you'll encode the DNA in new DNA, which will make the new virus in your DNA. But the mRNA from the vaccine is not going to do that. They don't have the primers for the reverse transcriptase. They're nowhere near the DNA, and they're not going to go there, okay, and they will degrade in the cytoplasm.
Yeah. Alan, could I also say that listening to some of the key vaccine experts in the world, they said that most long-term safety signals should appear within a month of vaccination. Yes. And currently about 50 million people have received 2 doses of Pfizer. So that is, a couple of weeks apart. And I think we should have begun to see if there were any safety signals. I think everybody is concerned about this, is monitoring this. And you mustn't forget there's also the trial subjects. There are thousands of trial subjects who are vaccinated, and those have been followed up for much longer, months, 6 to 9 months, some of them. So we haven't seen any, problems with them. So it's unlikely. No one can say some rare event does not happen 1 year from now, but those are going to be extremely uncommon events.
Yeah. Oh, that's happened even with other vaccines like influenza vaccine. Maybe you have a very rare Guillain-Barré, out of many millions of doses. Certainly can happen, but I don't think anything in that signal has emerged thus far with the Pfizer vaccine. But who knows further down the line, of course. But, we have to balance this with the efficacy of the vaccine, which is very high against protection against dying or severe COVID. And in the middle of a pandemic, you have to balance the risks and the benefits, and the risks you have to appreciate based on what is available data. We cannot have what I call what is known as spread FUD, FUD, fear, uncertainty, and doubt, just because we do not know what the future will be. I mean, this is and we need the facts, and we have to. And I like what you said. We need people in charge to be transparent about the data, so that the professionals on the ground can understand what is going on and can counsel our patients accordingly. And
And Ellen, we kill conspiracy theories by publishing the data openly. I mean, we make it clear what's happening. But I agree with you. I think the important message we mustn't forget is the deaths and the long COVID that's happening. Even now, if you look at our data, a lot of people are brought in dead. 10% of all our deaths are actually people who died suddenly and then were brought in. They died from COVID. So, and long COVID bothers many of us. There's a question there about long COVID data. And I think recently there was someone who spoke up about it from Sungai Buloh. I don't think he gave real figures or numbers, but he did say that, they haven't had opportunities to put up clinics for long COVID. They're swamped with the patient care work that they're doing. So there is long COVID in Malaysia, just that people haven't had the time to actually go and look hard at it.
Okay. So, Dashan, thank you for your question. Can a 93-year-old with ITP with multiple comorbidities take the COVID-19 vaccination?
This must be a relative. Yes. I think that people with ITP and low platelet counts, some of the advisories have said there's some concern. Even the MOH one said, discuss with your doctor. I think if your platelets are decent and the jab is not going to cause a bleed, I don't see any reason not to get the vaccine. Again, there's a risk that this individual has a very high risk of dying from COVID. Okay, but of course, this individual may also die in the next 1 year or 2 years. I hope they live till past 100. I pray for that, but they also may have that risk of a spontaneous death happening. So we have to weigh all that in thing. So I think yes. No contraindications as far as I can see, but should discuss with the team when you go in and do the vaccine and let them know you have these. But comorbids themselves are not a risk, is it, Ellen? Isn't it?
Comorbids are risk for COVID.
Yes.
Not so much for the vaccine. Yeah, it's like age and comorbids make him very vulnerable. But if it is ITP, the question arises: is this stable ITP not on treatment? If it's not on any immunosuppression, I think there's no signal that the vaccination is going to aggravate an autoimmune disease. So I think as far as generally speaking, autoimmune disease, the advisory from the American Society of Hematology is, yes, you can go ahead. If your immunosuppression is minimal, then, go ahead as well. But if you're on significant immunosuppression, then the concern is whether or not you're able to mount a response to the vaccine. So you got to discuss individually with your doctor whether or not it's suitable. But if it's certainly not on steroids or anything, it is, I think, highly desirable, I think, to be vaccinated at that age with comorbidities. My personal take, yeah.
Ellen, could I clarify what you said about immunosuppression? As far as I understand, it's not a real contraindication to the vaccine, just that the vaccine may not work in you. That's the main thing, probably. Yes.
Exactly, yes.
Correct.
So, I mean, there'll be varying degrees of immunosuppression, depends on what patients are on. But like, say, you're taking only 5 milligrams or 10 milligrams of prednisolone, that degree of immunosuppression probably will be all right for vaccination. Yeah. Okay. Thank you for wonderful session. Helps us keep calm. I don't know about you, Amar. The more we talk, also helps us keep calm. And if we can help our nurses, or those are nurses watching, or any healthcare staff, their concerns. Also, we hope at least your concerns are addressed. Okay. And Eugene also says thanks to you, Amar.
Thank you. Evelyn, I saw your comment out there, the coincidental deaths. Maybe it's a good word, I think the more we talk, the better the word we can come up. Coincidental deaths. Yep. But spontaneous, baseline, expected, so many words that people have used. Yes. I don't like the one fated because I don't really believe very much in that. Yeah.
Jack is asking patients on antiplatelets. I suppose you mean like aspirin or Plavix, that sort of thing.
You want to answer that, Alan?
No, I don't think so. Any concern?
Yeah.
I think
No.
just make sure you press properly after the injection so they don't bleed.
Yeah. Correct. In fact, I think I have that. I am on double antiplatelets and I usually press myself. I don't trust any staff to press. I press firmly and at least 10, 15 minutes. I don't even put a plaster. I just take a swab and press it there because I want to see exactly what's happening. So I just do that and that's fine.
Okay, thank you for your thank you, Shan. I don't know whether the 93-year-old, I remember your Facebook feed, you or somebody you mentioned had many innings. I think referring to your dad. A happy birthday to your belated happy birthday to your dad. Yeah, but I'm not sure whether it's the same individual. But I think we are dealing with a lot of elderly nowadays. A lot of people are living longer. 88. My mom is 88. She's registered. I helped her register for the vaccine as well, and I think she's on the waiting list. There we got 90-year-olds, 100-year-olds nowadays. Oldest I've seen is just over 100, I think, or hit 100. There might one old lady. Yeah. There's a question. Maybe you answer that, Amar.
Oh,
Since you know more information
this
than me.
is wider than what I planned to. I
Yeah.
think there are going to be a lot of people with different illnesses asking
Mm,
questions. Can I did it?
mm.
So again, I see no reason not to in this individual. And if you had Guillain-Barré and you were left with a disability, then you're higher risk of COVID death. Okay, if you had Guillain-Barré and recovered, also, I see no reason not to get the vaccine. Alan, what do you think? You're a physician, you might see more Guillain-Barré than I do.
No, I'm not a neurologist, so I don't see. But I do know I think it's pronounced Guillain-Barré. We have to pronounce it
Mhm,
Guillain-Barré disease, not Guillain-Barré. That's misspelled as well. Guillain-Barré disease can rarely happen after vaccination, like influenza,
mhm,
that I'm
mhm,
aware. But does that contraindicate COVID vaccination? I think we have to go back and look at the data and
mhm.
see. I can't answer that at the moment. I'm not an
Uh,
expert.
Yeah,
In
but at the present moment, I have not seen that in any advisory,
Mm,
contraindicating. But again, there may be many rare things that are not in advisories as well. Yes.
yeah.
Also, recognize that what we're saying is current for today, for the data that's available out there, and we must keep abreast of the data because we expect that it will change as more information is made available to us.
Okay. We also Google, so I've just done a quick Google for neurological disorders. This website, the International Guillain-Barré and CIDP, which is chronic inflammatory demyelinating polyneuropathy. Uh, what is their advisory? Yes, previous GBS may receive the COVID-19 vaccine. Yeah. Anyway, we'll have to research that because as Amar says, there are many individuals with rare diseases, and I think we got to look and see. Yeah. Okay. So yeah, Evelyn has Googled faster than me. So yeah. So that's your answer, Chua. Yeah. Oh, sorry, not
Thanks,
Leslie. Sorry. Yeah.
thanks, Evelyn.
Yeah, Chua. What about chronic disease and rheumatoid arthritis? Any concern for Sinovac?
Again, I don't see any concern. Again, I haven't seen the Sinovac data. Okay, I haven't seen the phase 3 data, which we need to see. So I think we should put off answering this question until that comes out. I think also our National Pharmaceutical Board will also give us advisory on this. Yeah.
And I think anybody with individual diseases is best to discuss with your physician because
Mm.
it's very variable. I mean, patients with rheumatoid arthritis could be on quite heavy
Mm.
immunosuppression. Same with people with chronic kidney disease. So we don't know whether you will be suitable for the vaccination. Because simply if you're on heavy immunosuppression, you may not be able to respond to the vaccine, for instance. But it certainly these comorbidities make you a bit more vulnerable if you get COVID. So you got to balance between that. But this one is a discussion or conversation which you should have with your individual doctor who has more information on your medical illness. Yeah. JK, is that Ju Kyung? Is that you, Ju Kyung? Our advisory suggests people on blood thinners should consult first. Don't know why.
So this, I presume, again, the whole question of aspirin and other, what do you think, blood thinners? Aspirin? What else would you consider blood thinners, Alan? I've lost your audio.
Sorry, I was muted. There was some noise in
Okay.
my background here.
Okay, yeah.
I presume anticoagulation like warfarin and
Oh, okay. I apologize. Okay, yeah. I'm not thinking straight. Okay, yeah. So I presume it's again the injection issue, isn't it? I can't think of any risk with the vaccine. It's just a risk from the needle. And, would you think of anything else, Alan?
I'm just trying to scratch my head what they are thinking about. Try to, yeah. So quick look up, yeah, vaccine. I mean, there's no. I don't know what our local. I'm not sure whether our local guidance does state that, but as far as the international guidance goes, there's no contraindication. Yeah. So I'm not sure.
Our local guidance does say if you're on blood thinners, you should consult your doctor. That is there in the
Okay.
NPRA, statement. Yeah.
I think basically again injection and bleeding.
Probably.
Yeah. As far as safety for the vaccine, yes, it is safe as far as I know. Yeah.
There's a question from Yap Soki about, should somebody who had COVID be recently vaccinated? I think we need to listen to MOH, what MOH says. But I saw this wonderful study recently that people who had COVID-19, when they vaccinated, their antibody levels went up really sky high. They produce a very, very good immune response just with one dose. So some people believe that the immunity is not going to be long lasting, and we should vaccinate anybody who had a COVID-19 infection before. But I'm waiting to see what MOH says about this.
I think my ID colleagues tell me the naturally acquired antibodies will wane maybe about 3-4 months down the line. So the current CDC guidance is vaccinate even if you had COVID. So if you want long protection, better immunity, even if you've had COVID before, you should be vaccinated. So that's my understanding. Yes, but I'm qualified. I'm not an ID physician or somebody treating, but this is somebody who's read the guidelines. Yeah. Let's see.
Yeah, I agree with you, Jack. I think we should make the incidence of all ADRs available. You see, we've lived in a climate where people have been cautious about sharing data. They feel that the public is not mature enough to handle, negative information. So for that reason, everybody says everything is rosy, everything's all right until, somebody leaks it all and then we'll have a massive meltdown in the country. I think that's our cycle in Malaysia repeatedly. I don't believe the public is that immature. The public can handle negative news, especially if you present it in a meaningful way. And then that counters conspiracy theories and counters people who have a personal agenda. So I agree with you. The Bell's palsy thing. Right now, the Bell palsy was initially thought to be a safety signal, but not anymore. I think the data from UK, if you look at the reports that they have published, there's no higher rate than the average population Bell's palsy in those vaccinated.
So we missed Sunita's comment. What's your thought on Covishield viral vector vaccine?
Not enough information to answer your question. Alan, you got some thoughts?
Oh no, I mean, it's very hard to catch up with all the data on the newer vaccines. So we'll have to look at the data. Then when we can comment meaningfully. At the moment, no, I can't comment. Not enough knowledge. Yeah. Mass vaccination center. Will doctors be there? Will they be able to give stat advice on specific medical issues? Certainly hope so.
Yes, I hope so. I that's why I like the Singapore advisory, and I think for doctors who haven't got anything, get a hold of it and read it. I think it's really very comprehensive, maybe a bit conservative, but still very comprehensive. I started seeing something like I circulated in the Dobbs group, one from Perak, where they talked about how to handle anaphylaxis, a key quick flow chart. I think all these tools must be available to us if we are manning the vaccine station. Okay.
Yeah. For the doctors out there, do join us on Dobbs. Lots of daily updates from Amar in Dobbs, Telegram, particularly Telegram, less so in Facebook. I think our Telegram seems to be more like serious sharing. Facebook, a little bit less serious sometimes, to be honest. If you need to join our Telegram group, please contact at Ketua Dobbs. Okay, so you look for Ketua Dobbs in the Telegram chat, and then if you're a registered Dobbs member, we will let you in. Yeah, okay. So a lot of good sharing on. It's like almost real time. I look forward to Telegram. I don't let my Telegram sort of overwhelm me, and it's like real time updates on COVID from around the world, shared by all the doctors in our group. Actually, it's fantastic. I thank all my colleagues who are so willing to share the updates and knowledge, and you too, Amar.
But
yeah.
I learned a lot, Alan, from there. A lot of people share very, very good documents, information. There's no way anybody is going to keep abreast of COVID-19 right now and the vaccines. And this kind of, wide reading by different people and sharing there helps us at least know the key points that are happening out there. And I wore red today because it's, Chinese New Year is just over, but I'm still in the China New Year mood, This year I didn't get to celebrate at all, which is very messy, yes.
Heck, I was on call. And I expected it to be quiet anyway. It was quiet, yeah. But things are becoming back to normal. We are really looking forward to life in Malaysia returning to normal, and don't think it's going to happen until there's mass vaccination. So I really hope the education and the message goes out there, so there's not that FUD, fear, uncertainty, and doubt, the FUD which goes out and spread by anti-vaxxers and things. I think people just need to listen to the science. Let's listen to the facts. Of course, we cannot predict the future, but to some extent, we can predict what's going to happen by what's happening already. You can have some trend, and if the trend and safety signals are there, effectiveness is there. I think we should listen to the data and not to imagine new concerns or worries. And I think we have to balance against the real threat. 1 in 5 will die if you're elderly and you get COVID. That 1 in 5. So I think if you want to protect your mom, your granny, and so on, I think you all have to be vaccinated if there's no contraindication. Yeah, Dr. Kaur's comment is practical and relevant.
Yeah, Kaur, I've thought about this, and I've also been thinking for Malaysia to achieve its vaccination program, we need to make it wider, a lot more people vaccinating than just few people. I think we're starting out, so we're cautious right now. UK, of course, has enlisted pharmacists to vaccinate. I don't really know their program in the nitty gritty, but I would assume that what they're doing is that they are filtering that anybody with a significant allergy or even a mild allergy is not coming to get a vaccination here. If you do that, you remove everybody with any form of allergic reaction to anything before and send that to a hospital or a place where they have better facilities, then the risk at the pharmacy is going to be very, very low for anaphylaxis. Anaphylaxis, of course, can happen to anybody. But I think now you're looking at something like, 1 per million or less. But I agree with you. I'm not sure they can able to handle the anaphylaxis. I think they would panic. I think they won't be able to resuscitate the patient. So I'm not sure whether it's a good or bad move, but they are trying to accelerate and thinking of the big picture. People are dying of COVID. Let's get the vaccine out. So they could balance. They're doing that kind of risk assessment, I suspect. And for that reason, they're trying to get the vaccine out quicker so they can reduce their mortality. The UK has had a huge mortality from COVID-19, and they're trying to dampen it down as quickly as possible. I suspect that's their thinking. But locally, our mortality has not been so high, so we may not take this route, or we may bring pharmacists into a center where there are also doctors vaccinating, and so someone can come and rescue you when there's a crisis.
Yeah, that's probably more sensible. You need more hands. I mean, nurses, pharmacists, not just doctors giving the
Yes,
vaccine.
agreed.
I think, but the center is the one which is capable of managing the anaphylaxis should it occur. Yeah. Okay. Any last few questions? So we've taken Amar's. We've gone more than an hour. This is my second webinar for the day, so it's a bit tiring. But anyway, anything to get the message across, I think it's important, and I hope people will share this video. The way to share the video is to, as they say, please hit the subscribe button, notification bell, and like. If you like this video, then apparently there's an algorithm with YouTube, and then so and so like you spread the thing and so on, so the message will get across. Okay, and subscribe and hit the notification bell for our channel, please, to help our channel grow so we can bring more videos like this to you. But if you like the video, and the more likes we have, I think YouTube sort of helps it make it more known, because every time you open YouTube, you get a list of videos which is recommended, just like Facebook. I think there's some funny algorithm, so you like it more, please, and then we will help us spread the word. Audio. Oh yeah, you're Jukyong. JK, yeah, Jukyong. Hi, Jukyong. And yeah, Jack, I'm very sorry about the grand rounds we had earlier this afternoon, where the audio was a little bit soft. We tested it, before, and we're using a conference microphone. It wasn't that good. It was a teaching grand rounds with the oncologist. So unfortunately, the audio was, I think people need to speak louder. Maybe we need to sit a bit closer and forget about SOP and distancing. Sit a bit closer to the mic. Yeah. Okay. So, thank you all for listening. Yeah. Highest number of participants for Saturday chat. Well, we hope you get more people who follow us and more people will listen. But again, it's testimony to the person speaking, the content. Yeah. So whenever Amar speaks, I think we get a lot of listeners.
No, I think it's a subject matter, Alan, and you are the one who dragged me here. I wasn't trying to do this.
Yeah, I'm sorry. But it's important, because this thing needs to get across. Yeah.
I am writing let's say, to the press on allergies. Because I think we need to get the message out in many different forms, and get people aware. I think we need to educate our public so that they can make informed decisions for their lives.
Yeah. Okay, so I think if we can probably end now, because I think, Amar, we need a bit of rest. I also need a bit of rest. And thank you so much, Amar, for your time. And thank you all for listening, and have a good weekend. Yeah. So,
good night, everyone.
Good night.